Dr. Kristi. Hi, everybody. I'm Dr. Kristi Maas. I'm very excited to be kicking off Reproductive Care Center's first Facebook Live program, and I'm hopeful and excited that other individuals will be able to do so in the future. Today we're doing some live question and answer, so please start rolling your comments and questions in. I'm super excited to answer anything that you have. Of note, I will not be able to give you personal medical advice. It'll be general questions and answers, and I don't have access to anybody's medical records. A little bit about our center. We're in Sandy, Utah. We have branches in Clearfield, Utah, and also service Wyoming and Idaho. There's 3 physicians. I'm the 3rd physician, joining Dr. Blauer and Dr. Heiner. And we provide care to individuals of all backgrounds requiring or interested in any type of fertility preservation or infertility treatment. So I'm excited to answer anything that people have questions about. I'm happy to walk each of you through kind of our basic infertility assessment and to get each of you going. I think right now we're still waiting for some questions to roll in. So I'll start with kind of what the basic infertility assessment looks like. Usually right now this is starting off with a fertility consult via telehealth or Zoom, unfortunately, because of our global pandemic. And that will include reviewing health history for anybody involved, whether that's individuals that are single or in same-sex relationships or in opposite-sex relationships that have been trying to conceive for some time, or if you're trying to face any type of fertility concerns or fertility preservation. That history includes personal history, that includes medical history, surgical history, family history, and reproductive history. And really importantly, we're going to talk about your goals. How many children do you want to have? What does your goal family look like? What does your timeline look like? And really my role is to help you figure out how to achieve that goal family. So treatment with goal of 1 child in a shorter timeline may be very different than recommendations for someone with a larger family goal over a more protracted timeline. The basic testing includes testing for all parts and pieces that are included for human reproduction. That type of testing for individuals with ovaries or eggs, follicle count, where we're looking at the ovaries and counting the number of little black circles on them, as well as a blood test. These 2 together can give us a relative assessment of egg supply. So it's either high, medium, or low. It doesn't tell us exactly how many eggs you have left, and that is an important question because as individuals with eggs, we're born with every egg we'll ever have, and our quality and quantity go down over time, but everybody's rate is a little bit different. Some people go much faster and some people are much slower, and things start to change much more quickly in our late 30s and early 40s. We also want to assess the anatomy. That includes the uterus, the fallopian tubes, and interestingly, most people think that sperm and egg meet together in the uterus. They actually meet in the far end of the fallopian tube and then have to travel down the fallopian tube over about the next week, then find a nice healthy spot to stick in the uterus and grow. That brings us to the last component, which is sperm. And we want to make sure that not only we have sperm, and interestingly, people can have an erection, they can orgasm and release fluid with the ejaculate, but not have sperm in that and not know unless I put it underneath of a microscope. And that allows us to look not only at how many million sperm we have per milliliter, but how are they swimming? Are they what I call either the Olympic athlete swimmers, swimming in a really nice straight line, trying to get out to that far into the fallopian tube where the egg is, or the little ones hanging out in the kiddie pool with the water wings just struggling to move around, the twitchers or the spinners per se. And that's really important because they do have a very long swim to that far end of the fallopian tube. Some couples feel like, hey, you know what? We tested everything. It looks great. I'm just going to keep trying. But that is actually what we would call unexplained infertility. If I do all of the tests, we find that we have eggs, or ovulating eggs, releasing an egg each month. We have a passageway for sperm and egg to meet through the uterus and fallopian tubes, and sperm number and quality looks appropriate, then that means that you would have a unexplained infertility diagnosis, which is up to 20 to 25% of couples. I just got my very, very nice first question. Do we treat male infertility? And we absolutely treat male infertility. We assess male factor infertility as well. And treatment doesn't always have to be high technology, high cost treatment. So it may be something where we talk about modifying your lifestyle. So avoiding toxins such as potential exposures to chemicals or radiation or use of tobacco or marijuana, or getting you started on a medication to try and boost sperm production. Additionally, we could do lower technology treatment where we wash the sperm, get the most healthy motile sperm, concentrated in a small volume and put it at the top of the uterus where it's halfway to that far into the tube. Or we can put sperm and egg together in a petri dish if needed via IVF. Next question, after having 2 miscarriages, do I recommend coming to see a fertility doctor? I do recommend a comprehensive assessment for multiple miscarriages. It's not technically infertility, it would be what we would call recurrent pregnancy loss or multiple miscarriages, and we do an assessment to figure out if there's contributing factors such as the immune system or hormonal factors such as the thyroid or the pituitary gland, or if there's anything anatomically contributing to this from the uterus or other abnormalities. Thanks for the questions, guys. Keep them rolling it in. I appreciate it. A little bit more about ways that we treat couples or individuals. We do have a very comprehensive array. One thing that I think most people don't consider part of an infertility practice's array of treatment is actually fertility preservation. And that can be something due to concern of time. So we mentioned earlier that women are born with every egg that they'll ever have, and quality and quantity of eggs decline over time. But this also could be for individuals that are facing treatments such as chemotherapy or radiation, or needing suppression of endometriosis or other factors that could potentially delay or impact fertility or reproduction. I have another great question rolling in. How does age impact the ability to become pregnant? I think this is most impactful for our female patients, and that's female patients or patients who have eggs. And that's because the egg supply is finite and it declines over time. And when we talk about decline, in general, we're still releasing 1 egg a month. It's just that the pool that our body is working from gets smaller and smaller. Our quality also declines over time. So at age 20, about 20% of the eggs have become abnormal. About 30% have become abnormal by about age 30. And about 70% have become abnormal by age 40. And abnormal eggs generally don't create a pregnancy. If they do, they're much more likely to result in a miscarriage. Male fertility is impacted with age, but it tends to be a little bit later on in life. So we see impacts in the 40s and 50s, and these don't tend to be a baby or no baby type of impact. They tend to be more health of baby, and they make common things slightly more common as sperm gets older, and uncommon things slightly less uncommon. So things like obsessive compulsive disorder, autism, those go up mildly. And then very rare things that you probably haven't heard of, such as neurofibromatosis or achondroplasia, become slightly less uncommon. Getting a little bit of questions now rolling in. Expectations during an initial consultation. We touched on that a little bit earlier, but this is a comprehensive history for all individuals that are involved or wanting to be involved biologically in the building of the pregnancy and creation of the pregnancy. as well as a family history to identify any risk factors that we should be aware of so that we not only achieve the goal of pregnancy, but our ultimate goal is healthy pregnancy and healthy baby after pregnancy. Next question, asking for a friend. Advice for someone that is 38 years old, has fears of infertility, and hesitant to see a doctor due to COVID. This is a great question, and I think that a lot of our healthcare has been put on hold, and I'm seeing this with a lot of my patients as well. We haven't been to primary care physicians or any management of any of our long-term issues because we've been avoiding having exposure in the healthcare system. And the great thing is we've converted over to a telehealth consultation system where individuals can receive advice, counseling, and information just like you are right now, over a computer, over video, and get their questions answered. And then, of course, our office has strict protocols to try and protect and reduce any risk of exposure. Everybody is wearing masks. We have specific hygiene, and we're social distancing. I do strongly recommend COVID vaccination for anybody that is planning to become pregnant, thinking about pregnancy at some distant time in the future, who is pregnant or who is breastfeeding because of the risks of COVID and pregnancy. And there clearly, to date, has never been any association between vaccination and infertility. So I just want to allay people's concerns. I know that was an initial concern, but there's no data that is supporting this. Next question, is egg freezing an option for women in their 30s who aren't in a relationship but who eventually want to have children? Absolutely, this is a great option, and I actually underwent egg freezing myself in my early 30s and had been married for almost 10 years. It was something that I felt was very important for myself to preserve fertility for the future. It's certainly not a guarantee, but eggs do decline in quality over time. So if we think of a 20-year-old egg versus a 40-year-old egg, a 20-year-old egg is going to be of higher quality. So it's going to take fewer eggs to achieve a pregnancy. And these eggs are frozen in time, meaning you could freeze them in your early 30s and come back postmenopausal in your mid-50s, and they're going to have the reproductive potential of the age at which the egg is frozen, which is really awesome. Next question. Baby 6 months ago at RCC with the last embryo. As far as endometriosis is a disease where the cells that line the uterus, which is called your endometrium, that generally build up and then shed each month when we have a period, are growing outside of that lining of the uterus. So they can be on the ovary or the fallopian tube or in the muscle. And in general, people that have endometriosis, our goal is to suppress that, and that's usually with something like hormonal contraception, or to achieve pregnancy as soon as we're ready to do so. So when we talk about timing of things, I think it's more about the timing of coming off of something that's suppressing the endometriosis, like birth control pills or a progesterone-eluting IUD, or the Nexplanon or Depo-Provera, something that has progesterone in it to keep the endometriosis kind of simmered down. And then as soon as you come off of that, we want to help you get pregnant readily, whether that's just instructing you on how to do ovulation predictor kits and timed intercourse, or if you have embryos in the bank, transferring an embryo, or if you need some sort of fertility treatment, starting fertility treatment sooner rather than later. Additionally, people with endometriosis can easily try to create embryos or freeze eggs for fertility preservation. I think of this in situations where people have had multiple surgeries for endometriosis, or recurrent cysts on the ovaries that are quite large and requiring recurrent surgery, because recurrent surgery to the ovaries can deplete your egg supply. And depleting the egg supply makes it more challenging as we get later on in life to achieve pregnancy. as far as intrauterine insemination questions, so IUI is intrauterine insemination, where we're taking the concentrated sperm specimen, we're placing it in a thin, flexible catheter and passing that through the cervix into the uterus. And everybody's cervix is curvy one way or another, as is the uterus. So some people hear, I have a tilted uterus. I'm like, great, so does everybody. But sometimes the cervix is curvier than others. I call them the Lombard Avenue cervixes, and sometimes they're really hard to get the catheter through. But just because it's hard to get the catheter through doesn't mean you have a lower chance of success. It just means that it's harder to get the catheter through. So it's easy to be concerned about that cervix. If we're thinking about intrauterine insemination transferring over to something like needing IVF, if we've failed multiple intrauterine inseminations, the catheter placement for embryo transfer is also a thin, flexible catheter that we pass through the cervix, but that is something that very, very rarely, I would say maybe once in my over 10 years of practice, has there been a situation we can't get a catheter into a uterus to transfer an embryo. We can always do cervical mapping, where we kind of diagram out and map a way to get into the uterus. And we can also do dilation of the cervix to help individuals get into the uterus as well. Let's go to our next questions here. Doesn't mean that you have to do the highest technology thing that we have. There are many lower technology treatments, and it may be as simple as, hey, let's talk about what the fertile window is. Let's make sure that we're timing sperm and egg exposure optimally, or we're doing something such as the insemination that I mentioned before, or medications to help someone ovulate or potentially enhance sperm production. Another question regarding testing for recurrent pregnancy loss. So primary causes that antiphospholipid antibodies, including lupus anticoagulant, anticardiolipin antibody, and anti-beta-2 glycoprotein. You don't have to remember each of those. Your doctor will remember them. But we also test for things like diabetes. We test for thyroid disease, and the thyroid is in your neck. It is what helps with metabolism. I think of it as the temperature setting when you're baking your bun in your oven, that you want to bake it at the right temperature. And so if that thyroid's a little off, it can impact embryo implantation and maintenance of pregnancy. Interestingly, thyroid requirements go up by about 1/3 in pregnancy. So people that have thyroid disease, the second that you know you're pregnant, you should start taking additional thyroid medication and have your thyroid monitored, and you should speak with your physician. Other things we talk about for recurrent miscarriage is looking at the uterus to make sure there aren't any abnormalities in the uterus. And then we also look at chromosomes or genetics. And the most common cause of miscarriage is genetic abnormality in the embryo, not necessarily in the egg source or the sperm source, but in the embryo. But when we get multiple miscarriages that are genetically abnormal, then we start to worry that maybe that's something that's being inherited from either the egg or the sperm, and that's why we look at the egg and sperm genetics. Next question, is IVF the best option for infertility? It is for some individuals, but it isn't for everyone. The majority of patients actually can start with lower insemination or optimizing health. We know that general health and well-being is very important for reproduction. So if we think about when cavemen and cavewomen were evolving, if we were at a point of starvation and just barely trying to survive, the menstrual cycle went away because people were not safe or healthy enough to reproduce or carry a pregnancy. So general health and well-being is incredibly important. Weight optimization is important, and you can be nutritionally starving by being underweight or overweight. And so we really want to optimize our health and well-being, and this is especially important for some of our patients that are struggling with things such as PCOS. So PCOS stands for polycystic ovarian syndrome, which personally I hate because it's not a matter of multiple cysts, it's actually little follicles or potential eggs. And this tends to be a disease where people do not have regular menstrual an egg regularly. And if I don't have an egg, it's really hard to create a pregnancy. But PCOS is very easily treatable, and I unfortunately often hear that patients with PCOS are told that they'll never be able to become pregnant, and that is absolutely not true. PCOS is something that is easily treatable. We can help individuals release eggs by using medications, and even health optimization, so weight reduction if you are overweight, by 5 to 10% can often be enough to get people to kick back into regular menstrual cycles. We know that BMI has a really important impact for miscarriage rate and pregnancy rate as well. So I think that optimizing our health in general, avoiding toxins, tobacco, vaping is huge now, marijuana, avoiding anything that could potentially hinder your chances or impact an ongoing pregnancy is strongly recommended. Other questions about how treatment impacts your day-to-day life. So during fertility treatment, especially after ovulation or sperm and egg exposure, then we ideally want you to treat yourself like you're pregnant. So we don't want you to smoke, drink, be exposed to chemicals, toxins, radiation. Caffeinated beverage, so one caffeinated beverage is okay per day, about 200 milligrams of caffeine. So a triple Java espresso probably wouldn't be recommended, but a standard cup of coffee, a hot tea, a soda or Coke, whatever you want to call it, those would all be okay in moderation. During fertility treatment, same thing. We don't want you having exposures to toxins while we're going through fertility treatment, but everything else in moderation is okay. During the IVF process, as the ovaries are growing multiple eggs and getting larger, we do recommend avoiding high impact activities. So no bouncing, running, jumping. I always say, please don't do gymnastics. This isn't the time to take up trampoline or gymnastics or something like that, because we don't want the ovaries to twist on the ligaments that hold them in place. If you think of all of our fertility models, if you remember back to your basic biology textbook, the ovaries were documented as sticking kind of straight out like a T from the uterus, but in reality they're held in place by floppy ligaments and they bounce up and down. And that's why we do want to have patients avoid the bouncing, because we don't want them to twist on those ligaments, because that's their blood supply and that would require emergency surgery to treat that. So we want to avoid that. Another question coming in regarding options for same-sex couples and family building. There's great options for people that want to build a family that are single, and people who want to build a family with someone that has the same reproductive gametes or portions. So if you are single, we can easily help single individuals with eggs, uterus, and fallopian tubes achieve pregnancy via something like intrauterine insemination from sperm donation. For individuals that are in a same-sex relationship and both individuals have uterus tubes and ovaries, we can plan to either do insemination for the individual that we plan to use their uterus and eggs at the same time. There's also another really fun and kind of one of my favorite opportunities for same-sex couples that have uterus and ovaries to both biologically be involved, whereby we create embryos using donated sperm and the egg from one partner, and that is transferred into the uterus of the other partner. So eggs from one, uterus from the other, and that's called partner-assisted reproduction, or PAR, or reciprocal IVF. For individuals that have sperm, if they are single or in a same-sex relationship, unfortunately, that is more involved because we do need to find donor eggs as well as find a gestational carrier to carry the pregnancy for them. But that could be done with same sperm source, or if we have two individuals that have sperm, sometimes split sperm source, clearly not in the same child. We only have one sperm source per child, but potentially in multiple different pregnancies. Other questions about aging and reproduction. Fertility does decline over time, but it's continuous. It's not like there's this cliff that unfortunately we've called age 35, and I feel like it was a bunch of white-haired older individuals sitting in a room saying, hey, what do we call 35-year-old women? And we call them geriatric pregnancies, which I think is kind of the most offensive term there is humanly possible. I have plenty of patients in their mid-30s or later 30s who are achieving pregnancy. Fertility does change more significantly around age 37, 38. The drop-off is a little steeper, and it does get much more challenging in our early 40s, and by mid-40s, it's exceedingly challenging. So I would say kind of in the 35 to 43 is the upper range for what I consider using someone's own eggs. Now, after 43, absolutely, people can get pregnant using eggs that they'd frozen at a younger age, or donated eggs or donated embryos, and we can actually take a menopausal uterus and make it carry a pregnancy. But we can do IVF at younger ages or more advanced ages, and there's actually some data saying that individuals in the 38 to 42 range may benefit by going more readily on to more advanced technology like IVF. Let's go a little bit back to menstrual cycle basics, and one of the questions is, tell me a little bit more about how my cycle is. And so day one of the menstrual cycle is defined as the first day of full flow. And some individuals will have spotting leading into that. That is not considered day one. Day one is full flow. And your cycle days, we start counting from that until the last days before your next period's first full flow day. So that's your menstrual cycle length. And generally that's somewhere in the 28-day range, but the range will be somewhere between 24 to 35 in most patients. If we're outside of that, then you would want to see a physician, whether it's a regular gynecologist or a reproductive endocrinologist such as myself, to have an assessment and understand why that cycle's a little bit off. Our peak fertility days are the day before we ovulate and the day before that. And I always get this question, well, how do I know when I ovulate? I pee on these ovulation predictor kits and they never tell me anything, and patients are peeing on a stick every day and driving themselves crazy, and it's pinching your pocketbook because they're not free. So if you have a regular menstrual cycle, and let's take a 28-day cycle, for example, your second half of your menstrual cycle, the time frame after you ovulate, for most patients is pretty well set at about 14 days. So in a 28-day cycle, if we subtract 14 days, then you're generally ovulating around cycle day number 14. So your peak fertility days are days 13 and days 12. Now, if we kind of use that same logic and we kick things out and we say, okay, well, actually I'm a 30-day cycle. Well, 30, I'm going to subtract 14 from that. I'm going to say, yeah, I'm probably ovulating around cycle day number 16. And so your peak fertility days are days 15 and days 14. And that, if you take your window and how wide your variability is, and most women have variability. Most women aren't like I'm every 28 days on the dot. Some are like, well, some months I'm 28, some months I'm 29, some months I'm 27. If you take your variability and you calculate that range out, that'll give you your fertile window. And sperm can live in the reproductive tract for 3 to 7 days, so they're pretty robust. The egg, on the other hand, lives for about 24 hours, which is why we say your peak fertility days are before you ovulate, because you want that sperm there ready and waiting at the end of the fallopian tube when you release the egg, so it's ready to fertilize and develop that embryo so it can travel down the tube to get to the uterus. Other things that I get asked about with menstrual cycles, how long should I continue to try on my own if I don't have a regular menstrual cycle? And that's actually an indication to get into either a regular gynecologist or a reproductive endocrinologist readily. Because if you're not having a regular menstrual cycle every single month, then you are not likely to be ovulating or releasing an egg every single month. And that makes it really hard to get pregnant. And we'd like to help you achieve ovulation so you can increase your chance of achieving that pregnancy that you're hoping for. I love these questions. You guys are doing awesome. Anything else, please feel free to ask questions. I'm here. I'm happy to answer anything, whether you're thinking, oh, this is a dumb question, everybody knows it, or if you're like, oh, this is really specific to myself. I'm happy to answer anything in general to the best of my ability. Other things that I have a lot of patients ask about are genetic testing. And sometimes I have people come in and they say, you know what, I have a family of 3 boys. I'd like a girl. And that is an option that we can provide. It does require IVF, where we're taking the egg out of the ovary, the sperm, putting them together in a petri dish, and then we are growing that to an embryo stage that's called a blastocyst, which is reached on days 5, 6, or 7 after sperm and egg have come together. And then we remove some cells from the outer area that becomes the placenta, and then we can send that off for genetic testing. And that genetic testing can tell us gender, but it also can tell us genetic normality or abnormality. It can be used to test for things. Let's say you have a strong family history of breast cancer, and you know that you carry the gene such as BRCA, which was developed up here at Myriad Genetics, and that increases your risk, and you don't want to pass that down to your children. We can test and create a pregnancy that doesn't carry that mutation if that's something that we are looking for. Other questions regarding luteal phase. So luteal phase is that 14-day period after ovulation before menstruation. And anything that is less than 10 days is considered a shorter luteal phase. And that happens, but it is quite uncommon. Pregnancy is possible with the shorter luteal phase. When you ovulate your egg and hopefully create your pregnancy, the pregnancy hormone, which is HCG, actually supports the corpus luteum, which is the cyst that popped the egg out, and it encourages it to continue producing progesterone and estrogen that support that pregnancy. So even if the luteal phase is shortened, it is possible to achieve pregnancy. I will say that there are some people that will be given progesterone, and unfortunately some people given progesterone at an inappropriate time in the menstrual cycle. So if you have concerns about your luteal phase, I would strongly encourage you to speak with your primary gynecologist or a reproductive endocrinologist to better understand what your luteal phase looks like, what the duration of that is, and if you need any additional support or testing for that. Other common questions include insurance and infertility treatment. And we do have some coverage for infertility treatment here in Utah. Unfortunately, not as wide as I'd like it to be. And that's certainly something that I think as a community, all of us can really start to advocate for. I know that there are some bills being passed and advocated for up at the state legislation. So please keep your eyes and ears out and advocate to try and get increased access to care in Utah. But there is some coverage here in Utah, and there is coverage for a lot of the testing. And much of my pre-pregnancy planning and fertility planning is just standard preconception labs that are covered by the majority of insurances. Treatment expenses can be quite variable. So again, I mentioned it may be recommendations for lifestyle changes, which are not expensive, or a fairly inexpensive pill that you take by mouth. Or it could be something that's more comprehensive, such as IVF, that is more costly, but the range is quite broad. So it could be from a few hundred to a few thousands to more. The amazing thing about RCC is that we offer discount plans, we offer financing, we offer package deals, and we really work with you to try and make whatever your treatment is doable, in not only the short term, but also the long term as well. And we really want to help you achieve your goal. We don't want cost to be that limiting factor for you to have the goal family. Other questions that I have are, how can I optimize my reproduction right now? And how will what I do now impact me in the future? And so again, back to that lifestyle optimization. So making sure that you're avoiding toxins. Please don't smoke. Smoking can not only damage the fallopian tubes, it can prematurely deplete your egg supply. So smokers go through menopause earlier than people that don't smoke. And it can impact the quality of the eggs that you have remaining. Other things, avoiding vaping, avoiding marijuana. Marijuana can definitely impact sperm, as can tobacco. Things that are more research-based as far as trying to maintain or help infertility, and these are primarily studies in mice or rodents, but there's a medication called ubiquinol or coenzyme Q10. You can pick it up at Costco, Rite Aid, whatever Target pharmacy you want. And that in mice was shown to help improve egg quality. If you extrapolate that data out to humans, you'd have to be on it for years and years, and you're fighting the time decline with the improvement of CoQ10. So I think of it more as a staving off of aging rather than egg improvement, but that is something you can consider adding to your supplements. And I would certainly recommend that you speak with your regular physician about that. There aren't any severe side effects from it, but definitely anytime you're initiating medications, discuss with your physician. I'd say be a little cautious with supplements because supplements are not regulated by the FDA. So there's a lot of, supplements and Chinese herbs and things like that are recommended. And I would say just use them with a little bit of caution and make sure that you're purchasing them from a reputable source. Be a little cautious if you're ordering them on Amazon to make sure where they're coming from. And then maintaining a healthy lifestyle. That's the main thing. The healthier you are in general, the more you can support and maintain your healthy reproduction. Moving on to the overall questions. There is fertility testing that we talked about at the beginning, and this is testing that can be done by ultrasound looking at the ovary, and we do something called an antral follicle count, which is the number of black circles on an ultrasound that gives me a rough idea of relative egg supply, high, medium, or low. And then we have other hormonal tests. One of them is called anti-Mullerian hormone. This gives me another relative assessment of egg supply. And then we have other tests called FSH and estradiol. FSH comes from the brain, estradiol comes from the ovary, and they communicate like a teeter-totter. So the brain yells at the ovary's like, all right, I'm doing my job. So it talks back with estrogen, and then once the brain hears that, it turns the FSH level down. Then we have other hormones such as inhibin that come from the ovary and LH that comes from the brain. And there are other scores or calculating aspects called an egg supply score. And this is done through a facility called Reprosource. It's a lab we send off on day 2, 3, or 4 of the menstrual cycle. And it gives us a rough estimate of egg supply. And that gives us kind of a rough estimate along with the ultrasound of how many eggs we might be able to get with fertility injection medications or fertility treatment. Fertility treatment is something that aims to rescue eggs that would have otherwise have died off for that month from dying off. So if I'm retrieving 20 eggs from the ovaries, I'm not depleting your egg supply for the future. I'm not damaging your ovaries. But what I am doing is trying to rescue 19 additional eggs beyond the one that you would have released on your own to use to try to create your pregnancy. So in nature, all of our eggs start off hibernating. In puberty, they start to wake up a little bit and things can be irregular. If you think back to when you first started having your period, it was a little unpredictable. Then after about 3 to 4 years maximum, usually it settles out and you start having regular menstrual cycles. And each month the body wakes up 1,000 eggs. The majority of them die off very early in the process of growth and development, but some of them will stay alive long enough that we can see them on ultrasound, and they are producing the hormones that we can detect on these blood tests. And those are the ones that I have the ability to potentially rescue with my fertility treatment and my medications. So unfortunately, I can't wake up the eggs for the next month or the next year. If I could steal them from the future, honestly, I would. Then people would only have to go through a fertility treatment once, and I'd take whatever egg I could and use it in a petri dish. But I only have the ability to rescue what I'm seeing on ultrasound, which is a rough estimate, not a perfect estimate, and what is being suggested by the egg supply score or the hormone testing. Hopefully that helps a little bit. I have a lot of my egg donors that will ask, well, I'm donating eggs. Am I going to have anything left for myself? And I go back to this, hey, you're donating eggs that would have otherwise have died off. And in nature, our body isn't really great at picking the right egg for each month. We have ones that die that may have been the right egg, and we ovulate the abnormal egg. And part of the reason I do what I do and why I'm so passionate about it is because when we're taught about human reproduction early on, when we're young, the general consensus is don't have sperm and egg exposure, because if you do, there's 100% chance you're going to get pregnant. And the reality is, at best, our peak fertility at age 20 is 22% chance per month. That's as good as it gets. And there's this concern of, don't have sperm and egg exposure, you're going to get pregnant. But then nobody ever tells you about the fact that people are born with every egg they'll ever have, that quality and quantity both go down over time, and that sperm quality goes down over time, despite the fact that sperm production tends to be maintained throughout lifetime, the quality decreases. And we spend so much time in our early reproductive education focused on, be careful, it's so easy to get pregnant, you just look at someone wrong and you're going to create a pregnancy, and nobody tells you that it could be hard. And then when patients come to see me, they're like, well, I thought this was going to be easy. I thought someone was going to look at me the wrong way and I was going to get pregnant. And 1 in 8 couples struggle with infertility. It's really common. If you're in a room, look around. Someone else is struggling right there with you. They may not be talking about it, but someone else is clearly struggling. And that's the hard part. And it can be struggling for first baby. And just because you had first baby easily doesn't mean that you won't struggle for subsequent children. That's called secondary infertility. And patients struggle with secondary infertility, and they struggle with the emotions of that, where they're like, well, I should just be grateful, I just have one. But it doesn't matter how big or small your family is. If you want more children, there's a desire and a need that is not yet fulfilled. And my pleasure in life, my happiness in life is really helping people fulfill that desire to complete their family, or to put something in the freezer for the future so that when they're ready to have that family, that's something that we can use to do so if we need to. If if I'm doing fertility preservation, that shouldn't be plan A. That's plan Z. Plan A is sperm and egg exposure, try and get pregnant on your own. If you're not pregnant, well, then we may do some sort of minimally invasive or smaller procedures to try and help you achieve pregnancy before we go all the way to using any type of egg or embryo or sperm that are in the freezer. You guys have been awesome. I love all the questions. It seems like things are slowing down a little bit. If anybody has questions, please throw out your questions. I'm happy to answer anything. One last kind of circling back to that fertility treatment and the number of eggs that we might be able to get. So in nature, yes, generally we release 1 egg a month, and that's whether we're 20, 30, or 40. When we're 20, it's more likely to be genetically normal versus when we're 40. And when we're doing fertility treatment and doing an assessment for that with the ultrasound or with the hormone levels, that gives me a rough estimate of how many eggs I might be able to get. But it's not perfect. It's an estimate. And some people do better than we expect. And that's great. We're happy when that happens. And other people don't do as well as we had hoped or estimated based on their testing. But the testing gives me a rough estimate. The best predictor of how you're going to do is how you did in a previous cycle. But if you haven't ever had a cycle, that's where we rely heavily on our ultrasound tests and our blood tests. Hopefully I've answered all of your questions. Any last minute questions, please feel free to throw them out. I'm here. I'm happy to answer questions. If you want to do more of a personal discussion, please reach out to Reproductive Care Center. We are happy to schedule a consultation with you. We'll review your personal history. We'll develop a personalized treatment plan for you and or your partner. And everything really is aimed at helping you achieve that goal family that you are looking for. And that may be now or that may be in the future. And we want to do it with the reproductive individuals that you hope to be involved in your family building. I take very little of the credit. I just put the right pieces together at the right place at the right time. You guys have the hard job. You get to raise the child and grow them into the amazing humans that I know each of you can. So thank you each for your time. Thank you for listening. Thank you for your wonderful questions. This was very enjoyable on my behalf, and I look forward to doing this again sometime in the near future. Stay tuned to our webpage and our Instagram and our Facebook, and we will continue to post our next events and updates. Have a great night. Stay safe.